This recording will go over assessment, analysis, and planning and implementation for colorectal cancer. When obtaining a patient history, ask the patient about major risk factors such as personal history of any other cancers, ulcerative colitis, Crohn's disease, familial papulosis or adenomas, polyps, or family history of colorectal cancer. Ask about whether the patient uses tobacco and/or alcohol. Assess his or her usual physical activity level, and ask about food preferences. Ask whether vomiting and changes in bowel elimination habits such as constipation or changes in the shape of stool with or without blood have been noted. The patient may also report fatigue related to anemias, abdominal fullness, vague abdominal pain, or unintentional weight loss. These symptoms suggest advanced disease. The signs and symptoms of colorectal cancer depend on the location of the tumor. However, the most common signs are rectal bleeding, anemia, and change in stool consistency or shape. Stools may contain microscopic amounts of blood that are occult, or the patient may have mahogany, dark-colored, or bright red stools. Tumors in the transverse or descending colon result in symptoms of obstruction as the growth of the tumor blocks the passage of stools. The patient may report gas pains, cramping, or incomplete evacuation. Tumors in the rectosigmoid colon are associated with hematochezia, the passage of red blood via the rectum, straining to pass stools, and narrowing of stools. Patients may report dull pain. Right-sided tumors can grow quite large without disrupting bowel patterns or appearance because the stool consistency is more liquid in this part of the colon. These tumors ulcerate and bleed intermittently, thus stools can be mahogany or dark-colored blood, contain mahogany or dark-colored blood. A mass may be palpated in the lower right quadrant, and the patient often has anemia secondary to blood loss. Examination of the abdomen begins with assessment for obvious distension or masses. Visible peristaltic waves accompanied by high-pitched or tinkling bowel sounds may indicate a partial bowel obstruction from the tumor. With auscultation, total absence of bowel sounds indicates a complete bowel obstruction. The examiner may perform a digital rectal examination to palpate the rectum and lower sigmoid colon for masses. Fecal occult blood testing should not be done with a specimen from a rectal examination because it is not reliable. A positive result could occur as a consequence of tissue trauma during the examination. The psychological consequences associated with the diagnosis of colorectal cancer are numerous. Patients must cope with a diagnosis that instills fear and anxiety about treatment, feelings that life has been disrupted, and need to search for ways to deal with the diagnosis and concern about family. Hemoglobin and hematocrit values are often decreased as a result of intermittent bleeding associated with the tumor. For some patients, that may be the first indication that a tumor is present. Colorectal cancer that has metastasized to the liver causes liver enzymes to be elevated. A positive test result for occult blood in the stool, or a fecal occult blood test, indicates bleeding in the GI tract. These tests can yield false positive results if certain vitamins or drugs are taken before the test. Depending on the age of the test being used, the patient may need to avoid aspirin, vitamin C, iron, and red meat for 48 hours before giving a stool sample. Also assess whether the patient is taking anti-inflammatory drugs. These drugs should be discontinued for a designated period before the test. 2 or 3 separate stool samples should be tested on 3 consecutive days. Negative results do not completely rule out the possibility of colorectal cancer. For this reason, additional testing may be suggested. Carcinoembryonic antigen, or CEA, is elevated in many people with colorectal cancer. The protein is not specifically associated with colorectal cancer, and it may be elevated in the presence of other benign or malignant diseases and in smokers. CEA is often used to monitor the effectiveness of treatment and to identify disease recurrence. Colonoscopy is the definitive test for the diagnosis of colorectal cancer. They can do a biopsy and get a tissue sample there. Also, polyps can be removed during colonoscopy for examination. The priority collaborative problems for patients with colorectal cancer include potential for metastasis due to colorectal cancer and potential for grieving due to a cancer diagnosis. The primary approach to treating colorectal cancer is to remove the entire tumor or as much of the tumor as possible to prevent or slow metastatic spread of the disease. Although surgical resection is the primary method used to control the disease, several adjuvant therapies are used. In terms of non-surgical management, the type of therapy used is based on the pathologic staging of the disease. The staging system used most often in colorectal cancer is the TNM classification, or tumor nodes metastasis. The administration of pre-op radiation therapy has not improved overall survival rates for colon cancer, but it has been effective in providing local and regional control of the disease. As a palliative measure, radiation therapy may be used to control pain, hemorrhage, bowel obstruction, or metastasis to the lung in advanced disease. For rectal cancer, unlike colon cancer, radiation therapy is almost always part of the treatment plan. Adjuvant chemotherapy after primary surgery is recommended for patients with stage 2 or 3 disease to interrupt the DNA production of cells and destroy them. Common side effects are diarrhea, mucositis, leukopenia, mouth ulcers, and peripheral neuropathy. Other medications used to help slow the growth of cancer cells include vascular endothelial growth factor inhibitors as well as epidermal growth factor receptor inhibitors. Surgical removal of the tumor with margins free of disease is the best method of ensuring removal of colorectal cancer. Many regional lymph nodes are removed and examined for the presence of cancer. The number of lymph nodes that contain cancer is a strong predictor of prognosis. The most common surgeries performed are colon resection, which is a removal of the tumor and regional lymph nodes with reanastomosis, colectomy, which is colon removal with colostomy, temporary or permanent, or ileostomy or ileoanal pull-through, and abdominoperineal AP resection. A colostomy is the surgical creation of an opening of the colon onto the surface of the abdomen. In regards to pre-op care, if a colostomy is planned, the surgeon consults with the certified wound ostomy continence nurse to recommend optimal placement of the ostomy. The ostomy nurse teaches the patient about the rationale and general principles of the ostomy care. In many settings, the ostomy nurse marks the patient's abdomen to indicate a potential ostomy site that will decrease the risk for complications. The patient who requires low rectal surgery is faced with the risk for post-op sexual dysfunction and urinary incontinence after surgery as a result of nerve damage during surgery. The surgeon discusses the risks for these problems with the patient before surgery and allows him or her to verbalize concerns and questions related to this risk before he or she gives informed consent. Reinforce teaching about abdominal surgery performed for the patient under general anesthesia and review the routines for turning and deep breathing. Teach the patient about methods for pain management to be used after surgery, such as PCA, epidural analgesia, or other methods. If the bowel is not obstructed or perforated, elective surgery is planned. The patient may be instructed to thoroughly clean the bowel or bowel prep to minimize bacterial growth and prevent complications. To reduce the risk of infection, the surgeon may prescribe 1 dose of oral or IV antibiotics to be given before surgical incision is made. Teach the patient that an NG tube may be placed for decompression of the stomach after surgery. Peripheral IV or central venous catheter is also placed for fluid and electrolyte replacement while the patient is NPO after surgery. Patients having minimally invasive surgeries do not need an NG tube. In regards to the operative procedure, for a colon resection, the portion of the colon with the tumor is excised and the 2 open ends of the bowel are irrigated before anastomosis or reattachment of the colon. If an anastomosis is not feasible because of the location of the tumor or inflammation of the bowel, a colostomy is created. A temporary or permanent colostomy may be created in the ascending, transverse, descending, or sigmoid colon. The ascending colostomy is done for right-sided tumors. The descending colostomy is done for left-sided tumors. The transverse double barrel colostomy is often used in such emergencies as intestinal obstruction or perforation because it can be created quickly. There are 2 stomas. The proximal one, closest to the small intestine, drains feces, while the distal stoma drains mucus. The sigmoid colostomy is done for rectal tumors. In regards to post-op care, patients who have an open colon resection without colostomy receive care similar to those who have any abdominal surgery. They typically have an NG tube after open surgery and receive IV PCA for the first 24 to 36 hours. After NG tube removal, the diet is slowly progressed from liquids to solid foods as tolerated. Patients who have had a laparoscopic surgery can eat solid foods very soon after the procedure. Because they usually have less pain, they're able to ambulate earlier than those who have had the conventional approach. The hospital stay is usually shorter with patients with a minimally invasive surgery. The colostomy should start functioning in 2 to 3 days after surgery. When it begins to function, the pouch may need to be emptied frequently because of excess gas collection. It should be emptied when it is 1/3 to 1/2 full of stool. Stool is liquid immediately after the surgery, but it becomes more solid depending on where in the colon the stoma was placed. For example, the stool from a colostomy in the ascending colon is liquid, the stool from a colostomy in the transverse colon is pasty, and the stool from a colostomy in the descending colon is more solid. Report any signs of problems related to colostomy, such as signs of ischemia or necrosis, a dark red, purplish, or black color or dryness to the stoma, unusual bleeding, and any sort of separation, a breakdown of the suture line securing the stoma to the abdominal wall. Also assess the condition of the peristomal skin around the stoma, and frequently check the pouch system for proper fit and signs of leakage. The skin should be intact, smooth, and without redness or excoriation. For an AP resection, the perineal wound is generally surgically closed with 2 bulb suction drains, such as JP drains, which are placed in the wound or through stab wounds near the wound. Monitor drainage from the perineal wound and cavity is important because of the possibility of infection and abscess formation. Serosanguinous drainage from the perineal wound may be observed for 1 to 2 months after surgery. Complete healing of the perineal wound may take 6 to 8 months. The patient may experience phantom rectal sensations because sympathetic innervation for rectal control has not been interrupted. Rectal pain and itching may occasionally occur after healing. Continually assess for signs of infection, abscess, or other complications, and implement methods for promoting wound drainage and comfort. Please review the chart regarding perineal wound care. In regards to assisting with the grieving process, the patient and family are faced with the possible loss or alteration in body functions. Nursing interventions are designed to help the patient and family plan effective strategies for expressing feelings of grief and developing coping skills. Observe and identify the patient and family's current methods of coping, effective sources of support used in past crises, the patient's and family's present perceptions of the health problem, and signs of anticipatory grief, such as denial, crying, anger, and withdrawal from usual relationships. Encourage the patient and family to verbalize feelings about the diagnosis, treatment, and anticipated alteration in body functions if a colostomy is planned. If a colostomy is planned, instruct the patient on what to expect about the appearance and care of the colostomy. After surgery, encourage him or her to look at and touch the stoma. Encourage the patient and family to verbalize feelings and identify fears to help move them through the appropriate phases of the grief process. In collaboration with the social worker or chaplain, help the patient identify personal coping strategies. Please review the care coordination and transition management section on your own, paying special attention to any boxes in the section, as well as the part about colostomy care.